Hi, everyone. Welcome once again to AJOG MFM Live. Delighted today to be talking about cerclage, a topic near and dear to my heart. We'll talk about cerclage technique. And we have an amazing panel of experts on this. I'm really excited to learn from them. I think you'll learn a lot from them as well. So we'll start introduction. Why don't I go around where I see people? Graham, do you want to introduce yourself?
Yeah, hi, I'm Graham Tideman. I'm a consultant obstetrician in Fife in Scotland, halfway between St Andrews and Edinburgh. And I'm more or less retired, but I'm still working on a lot of research and development projects, largely with uh, my hospital in Fife and King's St Thomas's in London.
Welcome, Graham. Laura, you want to introduce yourself?
What about you, Graham? Would you like, you're on mute, Laura. Do you want to say something?
Grant, yeah, hi, I'm Laura Stewart. I'm a senior trainee in obstetrics and gynecology based in Edinburgh, the Royal Infirmary.
Welcome as well. Andy?
Yeah, Vincenzo, thanks so much for inviting us. This is a really exciting topic and a great opportunity to be able to chat. So I'm an obstetrician based in London. I'm professor of obstetrics at King's College and I work at St Thomas's Hospital. I've got interest in clinical trials. I was actually brought up in Africa originally, so I have a big interest in global health, but I also do clinical trials related to preterm birth and preeclampsia. And I currently chair the FIGO preterm birth committee, and as you know, I'm very interested in clinical trials in the preterm birth arena. I've always been interested in innovation. I invented the QUIP app in preterm birth prediction and the cradle device for our low-income country work. But one of the most exciting things really was linking up with Graham and the team up in Scotland who really are the genius around a number of innovations which we've been pursuing more recently, and that's the topic of today, I think.
Yeah, and in a minute I'll give the slides and we'll start the presentation. One story I wanted to share of when I first really interacted with Andy, who is, as you can tell, super well known, a master at cerclages. I was sitting in 2011 at the Royal College. He was given a lecture. I had no idea what he was going to talk about. I think you introduced the new RCOG, NICE, whatever, cerclage guidelines, and you quoted our meta-analysis from that year. And yours was the first guideline that recommended cerclage for women with a proper birth and a short cervix, both of those criteria in single gestations. Then followed AJOG, followed SMFM. Today we won't talk about indications that much and evidence for effectiveness, but I think thanks to your work, your teams, our teams, others, I think cerclage is here to stay. Seems to work in certain populations really well. But the issue is the technique. It's how to do it, and so I'll give it up to I think you to start and go through the presentation. This is an article again published recently in the Pink Journal. Thank you.
Yeah, no, great. I was going to kick off just for 10 minutes or so and then hand over to Graham to give you some results from some research we're doing. Laura's here to keep us on the straight and narrow. She's the one who's done all the work. So just thank you for joining us, Laura. But just way of introduction, very briefly, I know many of you are experienced clinicians, but we basically want to focus in on technique, which is one of those things that just has not had attention with all the clinical trial evidence and all the clinical guidelines. And as Graham says here, we do them all very differently. We want to take you through the work we've done. So I just, again, very simple background here. We know that this is a very common procedure described 100 years ago, described in the literature in the late 50s by Shirodkar and MacDonald from Australia and in India and Australia. And actually 1 to 2% of all people in high income countries get this procedure. And there are literally hundreds of thousands of procedures done every year. But in spite of the number, the actual evidence base around what we should be doing and how we should be doing it has a very limited evidence base. The bottom line is, if you look at the randomized trials, most of the procedures we do make actually no difference to outcome. There's very high numbers needed to treat, over 30. Some evidence that different types of techniques like ultrasound indicated or even higher stitches may do better, as evidenced by things like abdominal cerclage. But it's an evidence desert, really. And the trials that do exist are kind of 20 years old often. This was a paper that I was involved with a group from London, 2017, that started to give us some clues as to things like the height of the stitch that matters. So the next slide demonstrates the very high headline evidence, which is essentially, if you measure the distance from the external os to the height that the stitch is, the higher it is, the better. And you can see that if the stitch is more than 10 millimeters from the external os, you're literally half as likely to deliver before 34 weeks, 20% versus 38%. If it's less than 10 millimeters. And if the higher you go, the better. But the trouble with all this evidence, of course, it's completely confounded by the clinical scenario. It's not randomized data. The in vitro measurements are also confounded by physiological change and other change that goes on pathologically. So we don't, and it's really difficult to standardize any technique. The next slide demonstrates another paper that's just come out this month in the Pink Journal, also suggesting from our clinical trials in Cerclage that the mechanism of why they work, for example, abdominal cerclages, is because they are placed higher. And that data is getting stronger and stronger. If you look at the next trial, though, this was another group that I was involved with in the UK, where we randomized people to different types of sutures, in this case, monofilament versus braided, with the theory that the infection story is important. And this illustrates the fact that you literally have to randomize thousands of patients to just prove that one variable is or isn't different in the clinical scenario. And actually, after all the money and effort and 60 centers randomizing over a number of years, we basically demonstrated nothing. There's no difference between the two. So it's sort of really hard to get evidence just on one variable, never mind the multiple variables when it comes to surgical technique. So the next slide, really, this was the birth of our idea. And in fact, Graham needs to be credited with this brilliant idea of coming up with this simulator after we had discussions together saying this would be a good idea. And again, we published in the Pink Journal recently the experience of developing the simulator and then creating it in order to gain evidence and experience on technique. If you look at the next slide, the bottom line is we had a really pleasing result with our first experience. Clinicians found it to be very realistic, very suitable for skills training. You can imagine working up a hole and swinging a needle in a confined space and so on. You don't really want to be doing that the first time on a real patient, if at all possible, because you are near delicate, potentially harmful areas, and you want to do it well. And of course, the novice participants said they liked this. It improved their confidence. And when we looked at experts versus novices, we did find some significant variation. So my final slide really is to show that one of the really clever ideas from the simulator was we could have a cervix that could be removed and evaluated afterwards. And this therefore allows us to do research in a very standardized way, and really was the birth of the study that I'm going to hand over to Graham now to tell you about.
Yeah, thank you, Andy. This is a working drawing of the cervix, the removable part. I have some behind me I can show you afterwards. But there's two things I want to bring your attention to here. One is the cervical canal is parallel and 6 millimeters diameter. The cervix is 32 millimeters diameter, which seems about right. So it's 13 millimeters from the outside until you enter the canal. The other thing is, it's actually quite a long cervix. If you pull quite hard, it can come down, and it's knocking on 50 millimeters, 5 centimeters long, which of course is longer than you'd almost ever do a stitch. But part of the reason for that was it's much easier to show variation in the way people do things, and much easier to train someone if you say, oh, hang on, you've put that one way too low, or that one's really nice and high. There's a bigger difference, bigger opportunity for error. So that's part of the reason it was designed that way. So there's a short video now of just me, how I do one, and there's a much longer version of this on YouTube. There's also an emergency cerclage. Now, I'm not for any moment suggesting this is the perfect way, but this is how I do one. This is kind of our starting point, if you like, and it's only about 20 seconds long, so I'll play that now.
That's lovely. I'm going to take my first bite as high as I can, and then possibly even higher. I'm going to go deep enough so I get some cervical stroma and I can feel that, but no more deep than I have to. I want my suture to circumference as much cervix as possible. So Daisy, if we now go to 11 o'clock and 7 o'clock, I'm then going to come down this way. I'm going to rotate the cervix a little bit, if it'll let me, and grab another bite. And by tying a slip knot and with pulling, Daisy, pull a little bit harder, I can make the effect of the knot even higher still, and I can feel that tightening up, and I'm doing it almost, but not quite as tight as I can.
Yeah, so a very brief thing. Proud dad. I've got to mention my daughter Daisy, who's a design engineer and worked on the development of this. So what did we do? We presented this simulator through a variety of meetings a couple of years ago in Britain. And we said, this is our simulator, what do you think? And then, as Andy said, went on to evaluate it. And then we said, would anyone like to take part in a trial? And what we asked people is, are you the person in your hospital who does them? Are you, put your hand up if you want to take part. Are you the local representative for Cerclage? Because it tends to work like that in the UK. And we ended up with 28 different specialists, 28 consultants in 16 hospitals in 11 UK cities, the length and breadth of the country. And we just said, do a couple of cerclages with your usual suture, so we can see what you normally use. And if you use both tape and monofilament, which a lot of us had to become familiar with because we were randomized into them as part of the C-stitch study, do one of each. So we ended up with 52 cerclage. And as Andy hinted at earlier, quite small numbers, but when you take out biological variation, you don't need big numbers. And we just measured everything. We took a note of the suture, what type it was, what needle diameter it was, how many bites they did, how high they went, how deep they went, whether the knot was anterior, posterior, whether the length of the thread, and how tight they tied it. So how did we achieve that? Well, the height of the bite's really easy to measure. You just get a set of calipers and you measure height. And when they started coming back in the post to me, amazing. Clearly this person doesn't think that high is important, and this person thinks that high is really important. Just interesting straight off the bat how much variation there was as they started landing back in my office. To get depth and tension, we had to credit Wendy here in our CT scan department, who did a CT scan on every single cervix, and each cervix was labeled so we could identify it through the scanner, and then measure the depth and tension. And we measured the tension in the stitch by the reduction in area. So looking at some results where we had 20 tape and 32 monofilament, and needle diameters 31 to 48 millimeters. Now, in the UK, if you use tape, you're obliged to use a 48 millimeter needle. The tape we have here is Merceline tape, and you can't get it on a smaller needle. But what really interested me, again, when they started coming back, we asked people to send back their open suture packet, was that some people were using monofilament with a really big needle. Now, personally, one of my great pleasures of doing the C-stitch study was go, oh, at least I don't have to use that great big needle. Almost everyone using a round body, but amazingly, 4 people using a cutting needle, and quite a big variation in the number of bites. Some people just doing 2 bites, front to back and then back to front, and about 80%, well, exactly 80%, left their knot anterior. What we also analysed by a loop, which I don't know if is common worldwide, but certainly 50% of places in the UK, they tie another knot here. And I was taught to do it that way, but I stopped years ago after we had a few patients come in where the registrar at 4 o'clock in the morning with a woman in early labour found the knot after some difficulty and then just cut here and then started to pull and really pull. But interestingly, still half people are tying a loop. And this sort of stuff surely should be easy to standardize, because our women do turn up in other people's units, not necessarily with their notes. So a simple consensus on that, you'd like to think would be achievable. The height of bites, as I said, really easy to measure. A mean for a cervix that from there to there is nearly 50 millimeters, 48 millimeters, a mean of about 2/3 the way up the cervix of 33 millimeters, but a huge range. Some people as high as it's possible to get. Now, when I say mean here, if someone did 5 bites, then it's the average, the mean of each bite. So we measured where it went in, where it came out, where it went in, where it came out. So some people achieving very high consistency, and other people much less so, as illustrated by this graph. So this is just the people with the lowest mean. So the mean of all their bites was only 15 millimeters. Other people up here, 48. But the green bar is the variation. Some people are putting their stitch in as a circle around the cervix, and some people zigzagging their way up and down, maybe a high bite one point and then a lower bite and a higher bite and a lower bite. And it's not clear whether this is deliberate or accidental. So we looked at whether maybe it was more difficult to get a bite right up if it was anterior, or more difficult to get a high bite if it was posterior, but actually there was no difference. And this one here, a mean of about 25 millimeters. The highest bite was 35, the lowest bite was about 25 millimeters. So quite a lot of difference the way we do them. The depth of bite, this again, fascinating stuff. This person here, which we'll zoom in on here, went through there, out there. The material went there and there, through there, out there. So 2 bites here with the knot here. And it's very easy to measure the depth, but you can clearly see straight through the cervical canal with their first bite, or their final bite, one of them. So when we looked at this, and this is the 13 millimeters I referred to earlier on, there were 2 or 3 people where there, 2 nearly, 2 definitely, where the average, the mean of all the bites they did was deep enough to go through the cervical canal. And that really interests me for 2 reasons. One is each time they put a suture in, they were at risk of entering the cervical canal. And again, when you think of our model of having parallel cervix, in most women it won't be parallel. There'll be some degree of funneling. So it's likely that the higher you are, the shallower you have to be, without risk of either getting that needle through and either adjacent to the amniotic sac or possibly even rupturing it. But also, it's always occurred to me that the deeper you go, the less cervix is being squeezed. If you go all the way around the cervical canal, a little circle, you're not actually achieving a squeeze. But interesting, what a variation. And if you look at the other aspect of this, we look at the variation. 7 people put 1 or more. So 14% of all cerclages by experts in the UK, 1 or more of their bites went deep enough to enter the cervical canal. Tension was interesting. This person went quite deep, not as deep as many, but nice 1, 2, 3, 4, clearly tied that knot really tightly. You can see it squashed right down. And I've got to actually thank this person. I knew the mathematical area of the area of the cervix, but we were measuring these on the PAC scanner and on the CT imager. And what I meant to do is to put in a control, but I found out I didn't need to, because this one put one in with no tension at all because the knot wasn't tied. So actually we were able to compare the reduction in area to the sample without having to ask Wendy to rescan yet another one. So when we look at tension, again, absolutely no tension in one. Some people reducing by 40 or more percent reduction in area, really squashing it down. Thread length may seem trivial, but I think the person who tied this one, it's a long time since they were on labour ward, and they were the person who had to, at 4 o'clock in the morning, struggle away to find a thread to remove it with the woman in early labour. And again, harking back to the C-stitch study, which showed a higher percentage of general anaesthetic, higher percentage of anaesthetics required to remove monofilaments than tape, presumably because they're easier to see, particularly if they're cut short. I mean, this one was an outlier. That presumably would have been nearly to the knees. But again, you'd like to think we could achieve some kind of consensus. So when our trainees, or when we've got our poor women coming in labour, well, at least we know how to find them. Thread length again, look at this. So 150 millimeters, 6 inches down to half an inch for the American audience. So massive variability. So we did some analysis. Well, in fact, the statistician on the group, one of my other daughters, Flossie, sorry, I've got to keep plugging this. So we showed there was a highly significance, P0005, greater height with monofilament versus tape. Now, then we asked ourselves, is that a feature of the monofilament or the tape, or is that a feature of the fact that the tape only comes in a 48 millimeter needle? Well, actually, the 31 millimeter needle was significantly higher than all other needles. So the 40 and 45 millimeter needles were with monofilament. And so a smaller needle does seem to result in a much higher placement. But what we didn't find was any associations between the suture type or needle diameter with the depth of bites, how tight people tied it. I was surprised at that. I thought it would be much easier to tie it tight with the tape or the length of cut thread. We thought initially, just looking at the scatter plot I'm going to show you in a moment, that there would be no association between height and tension. In fact, there was a very loose association. There is, in fact, a trend line, but this final slide of the data really says it all for me. So, we're all over the place. This is how tight you do it. This is actually the starting area of 814 millimeters squared, and that's 300 millimeters. So some people really high up the cervix, 40, nearly 50 millimeters, and really tight. But some people really tight and low down, and some people high up and barely any tension at all, like this one, 35 millimeters. Effectively, that was the one with no reduction in area at all. But there are others, he's not on his own there, or they are not on their own. Sorry, I don't know whether it's a he or she. If we move on to what does this actually mean? Well, as Andy hinted, this is a snapshot from the Cochrane study. We don't know. When we do studies on Cerclage, we get variable results. The confidence intervals and the means are on either side of unity quite frequently. So we don't really know. And actually, when you stop and think about it, and this is one of Andy's points, it's a bit like when we do a surgical trial, it's a bit like doing a drug trial and saying, let's find out if drug A or drug B works the best. And, oh, by the way, you can take any preparation you like, you can take it as often as you like, you can take any strength you like, and then we'll randomize you and find out which works. So, surely at least we ought to be able to standardize to some extent. So our thoughts and the thoughts for discussion is it possible to agree a consensus? Can we do some kind of Delphi consensus procedure and actually agree what a good stitch should be? And then, interestingly, a bit like an audit loop, we ought to then show in a similar study to this on the simulator that it is repeatable. So you can aspire to do it, but can actually people achieve it over and over again on the simulator? And then for future surgical trials we then have a simulator that's then validated and an agreement of what we should achieve. Let's check that people can actually achieve that before we subject our women to trials where we may not get results simply because people are doing them differently rather than whether or not it works. So with great thanks to all the co-participants, Andy and Laura on the call and the rest of the authors. I'm going to hand back to Vince so we can hopefully have some very interesting discussion. Thank you very much.
Thanks, Graham. That's great. One of the things I'm thinking, Andy, and feel free to chime in, is maybe we could go through a Cerclage kind of from the beginning, and go step by step on all the stuff that Graham went through, and kind of not only look at the data that he presented, but say what are the data maybe out there, and what we do in real life. One thing for background, I'll share real quick a slide. Is that obviously this may make a difference according to what kind of cerclage you're doing, because I know that, and you can show them if you want, Graham, as we talk. You may have a long and closed cervix and place a 12-week, what we like to call history-indicated cerclage. You can do a cerclage based on the fact that the cervix is short but still closed on exam, what we've called ultrasound-indicated cerclage, or you can also, you were alluding to, Graham, do a physical exam indicated cerclage. Membranes are prolapsing, the cervix is 1, 2, 3 centimeters dilated, and obviously tension, height, depth in particular, the cerclage depends on this. I need to acknowledge Jason Baxter in our I think back now almost 20 years ago to come up with this idea of nomenclature, which has been taken off by many others. When it's hard to use so many other terms that you see in the slides that mean different things, but I think these three terms seems to be somewhat well accepted. So maybe we'll do that if it's okay with you, and start from how we go through a cerclage. Is that okay, Andy?
Yeah, sure.
One thing, the I was going to say, how do you even, before you start a cerclage, how do you even clean the vaginal wall, if at all? Do you use iodine, chlorhexidine?
It's such an interesting point, Vincenzo. I often wonder whether the actual intervention is partly the microbiome benefit of,
right,
septic. And I say you almost have to do a sham procedure of everything, including the cleaning up, without the cerclage in a proper trial. And we don't know how good the stitch is compared to the other things we're doing that may be different and beneficial in this situation. So I do clean, and I do tend to use chlorhexidine. I saw a study many years ago, which I don't think was ever published, that suggested that iodine may have some caustic effects on membranes, and with ultrasound indicated sutures often having that track to the membranes, and obviously physical exam indicated sutures do. You perhaps want to avoid iodine, but I have no real evidence for that, so we tend to use chlorhexidine unless it's not available, like it was this morning, where I ended up using iodine. So we do clean.
I know you're just coming from a cerclage. You just did it a few minutes ago.
Yes, exactly. So yes, I think so. We don't know the evidence base around it, but I think local antiseptic cleaning seems to be reasonable for surgical procedures on a skin that is known to have a lot of microbiome. I tend to avoid antibiotics systemically unless I'm really worried that something has happened with a physical exam indicated suture.
Graham, any comments on that?
No, I'd agree. I mean, we're guessing, aren't we? But I would clean up with chlorhexidine. I wouldn't use antibiotics.
And we can come back to antibiotics. Yeah. I mean, I as you start, well, actually, we can talk about it in a second. Another thing, kind of at the beginning, it's how you retract. One of the issues, it's nice to have a simulator, and you can go as high as you want, but sometimes it's really hard to get high, on the cervix. We have women with high BMI. Obviously, this is a graph from years ago. We tend to use a weighted speculum at the bottom, as you see here. It's interesting, and we have what they're called Braskis retractors. They're nice and long on the side, and another retractor anteriorly. And it's interesting, in your slides, you showed ring forceps. And actually, unlike this graph, which is a little old, we have usually one ring forceps on the anterior lip and one on the posterior lip. And I think you seem to do the same. Is that correct?
Yeah, that would be normal. Although I heard some evidence recently that, again, in vitro studies rather than on real women, that if you actually use a toothed instrument, you end up with net less trauma than a sponge forceps. But I haven't. Well, have you come across that, Andy?
You know, I mean, I've always used sponge forceps, to be honest, because they're
Yeah.
easily available and often there for the
And sponge forceps for our audience is the same as this one's, right? Ring
Yeah.
forceps. Yeah.
Ramp, please,
Call
or
them sponge or ring.
I was kind of taught that it's relatively atraumatic, and that's why we use it. And I think if you have a normal cervix, it's quite easy to manipulate the direction it is and help access. However, as you say, I think when we do difficult ones with scarring and following LEAP procedures and so on, you sometimes find it hard to get the sponge forceps on, or and therefore a little kind of tissue forceps like an Alice or something like that, or even a tenaculum or something ending up being less traumatic, even though it's the actual end of the needle appears to be more traumatic. So I think you have to tailor your instrument according to the clinical circumstance.
And, and I teach trainees, this, as you call them, sponge or ring forceps. You need to make sure you have enough of a bite. Many people are afraid to bite on the cervix, and then it comes off, and you get more bleeding, more trauma. So I really, like in this picture, make sure that, the whole ring, for example, it's on the anterior lip or on the posterior lip. Go ahead.
Yeah, absolutely. The worst thing you can do is be timid and then pull off a chunk of cervix
right,
grabbing it securely. Because as Andy was alluding to, if you've got, what I find, and I'm sure it's common practice, that you think initially there's hardly any cervix sometimes, particularly for a woman who's had several LETS procedures. And then you can, with patience and time, you milk the cervix down into the vagina, and actually you can end up with quite a decent length cervix to put your stitch on if you take your time.
And one thing I always teach my juniors, Vincenzo, is when I've gone around in clinical trials to evaluate people's procedures, everyone has their own way of doing it. And the other thing is they all swear that is the only way to do it, and any other way is worse. And I think just seeing the variation in clinical practice is quite staggering. And I say to juniors, well, look, there's more than one way to skin a cat. You have to kind of learn that to change your practice according to evidence and according to clinical need on an individual basis. And we should have that variation so we can learn and progress, and don't just be dogma about this is the only way to do it.
Yeah, and like you did the sutures trial, we'll talk about in a few minutes. I'm looking forward to more trials, looking at different aspects we're going to talk about. I think, I teach about C-section as well. There are probably 100+ C-section steps, and we all do them differently. Cerclage, there may not be 100, but there probably are 20, 30 things that we're going to go over through today, and Graham already showed. And we need to evaluate each one, in the future.
I think so, though. I think there are some where we can say this is almost certainly a bad idea, like going so deep that you enter the cervical canal.
Right.
I think if people knew that they were doing that, they probably wouldn't. That seems to make some sense.
Yeah. What about the dilators? Exposures. Do you do something similar to what we do, or any tricks? Again, even on a history indicated, normal cervix. What kind of exposure do you look for? Andy?
Sorry, I
Sorry,
don't.
I mean, you're putting a dilator into the internal lobe?
No, not dilator. Sorry, a retractor. Sorry.
I was getting worried there. Well,
Yeah, me too.
Retractors, not the 4 retractors I'm showing here, for example.
Lost in translation, a transatlantic problem.
Yeah,
No, it's okay.
No,
I mean, I find good assistants are essential. And I say, these long L-type retractors are really useful. The thing I say to my assistants, first of all, I tell them that the procedure is very easy if you have good assistants.
Yeah.
That immediately stops them falling asleep and concentrating, because they think it's all up to them how good the procedure is. So you want a couple of people who are used to it, particularly if you've got a difficult case. You want to get someone experienced who knows what you're trying to do, so that they can help you. And I think the retractors probably aren't as important as the assistant. But I like having handheld retractors so the assistant can be dynamic and show you where you're going, and you can move around and expose, different parts as you need to get to it, rather than having a fixed retractor. That's my preference.
Yeah, I'd mirror that. The thing I have a bit of OCD about it, so I always insist, where possible, on two assistants, one sitting next to me who's usually a senior trainee about to do them, and one standing. But the one standing, of course, can't see anything, so we do a little rehearsal of round the clock, like in that little video. So when I say put your retractors at 1 o'clock and 7 o'clock, there's no confusion about what they mean in advance. So just that, like you would for any procedure, the less fiddling about you do, presumably, the better. So the more you've established the communication in advance, the quicker it is, better for everyone.
And usually, for example, I'm thinking of that so many cerclages we do. We have 3 people. I find it's good, to do vaginal surgery. So there is usually one of the trainees, in the middle doing the cerclage, unless it's really complicated. But usually the ones, kind of placing the needle. And then there are 2 on the side. One kind of holding. I don't know if you can see my name, but let's say the left on the screen, Baraski's retractor, lateral retractor, making sure that side is really well seen to place the first needle kind of from whatever that is, from 11 to 10 p.m. and to the 10 on the clock. And the other one is making sure that, anteriorly the retractor doesn't fall, and also that the weighted speculum, kind of doesn't fall. And then we switch sometimes, but with the middle, primary surgeons kind of doing the stitch. But I agree with Andy that I think exposure and good retraction, it's so key. Let me go back, if I might, to the antibiotic issue. I'm going to show a different slide, if I might, real quick. And I know it's controversial and there's not that much evidence. As you know, Dr. Miller in Chicago did a randomized trial and showed that for physical exam-indicated cerclage, there was a benefit, and she used the ANSEF, really 1 dose. If you look at the details of that trial, this is amniocentesis, but it relates to the rate of infection. Therefore, use of antibiotics. We never use antibiotics or amnio, if the cervix is nice and long and 12 weeks is ready to get cerclage. We actually rarely use an amnio, since it's pretty low of infection if the cervix is only 20, 15 millimeters short, but it's closed on the external os. And we may mention amniocentesis, antibiotics, but we don't do them routinely. And we give ANSEF if somebody's 1 to 3 centimeters dilated, a physical exam-indicated cerclage, since the incident infection is so high. And I would say maybe half of our patients agree to an amnio to make sure that they're not infected. And if they have a glucose of less than 15, or if the gram stain is positive, which comes back in about an hour, we do not do the cerclage, and we recommend for actually delivery. We're doing a randomized studies actually on adding azithromycin to the ANSEF in physical exam-indicated cerclage. We've randomized about 40 out of 50 here in Philadelphia. Jenny, one of our fellows, is doing that trial as PI. So we'll have more data. But it sounds like, Andy, you also use antibiotics maybe for just somebody with an open cervix.
Certainly, we're very familiar with your work, Vincenzo, and the work going on in North America on this area, which is very critical. My own practice at the moment is to give a course of antibiotics at the time of the procedure if it's, a physical exam indicated cerclage. Again, very pragmatically, our view is we get the stitch in quickly, we get it out quickly when it goes wrong, because it's so difficult to predict. Our women and our clinicians don't like doing amnio in these high-risk situations, although I accept that the diagnostics are quite critical in decision-making. We are working very hard in finding non-invasive inflammatory markers that will help give us good clues as to intraamniotic infection. without having to stick a needle into the sac. And I think that's a big area for future research.
Graham, anything to add?
No, nothing to add to that. I don't think I've come across anyone doing an amniocentesis in the UK prior to rescue.
Oh, wow.
Yeah.
Interesting. Yeah.
It's very uncommon. We read about it and then we're sort of too frightened to go there with a needle, mainly because of, we presume there's an increased risk of just causing problems with the amniocentesis, albeit very small.
Yeah.
We have done them in our clinical studies, but I think in routine clinical practice it's quite rare.
I guess I'll ask you a somewhat related question. We do give indomethacin for about 48 hours, especially to physically examinated cerclages, open cervix, but also to somebody who has a short cervix, based on retrospective data and the fact that some of the trials, the cerclage trials, including ours, we gave indomethacin on top of the cerclage pretty routinely if it was a short cervix or an open cervix. But that may be only US practice. Do you do that in the UK or Scotland?
I can see why people do it, and I'm a great believer of go with evidence-based practice and do the trials in the unevidence-based areas. So we generally don't add in extracurricular, therapeutics at the moment, and including antibiotics, tocolysis, and so on. Accepting that there may be a role to play, but we just don't know. And I think there's a temptation in very high-risk situations to try everything because you're worried. And I think we generally try not to, so that we can keep the evidence as clean as possible. And we let you clever guys work it out in the meantime.
Yeah, and that would be my experience as well. We used to use various things in the belief that they were making a difference, but at the moment I think it's largely fallen out of practice, possibly nifedipine.
Okay. Sounds good. Let me show you real quick, one of the reason, when we did that analysis in the White Journal in 2017, where we were looking at, so to speak, low risk women, so singleton, no prior preterm birth, but a short cervix. And this were a small sample. We were looking at adding indomethacin, which was most of the tocolytic here, and adding, 1 dose of antibiotics. This was not, perfect, and they were not randomized to indomethacin or not, antibiotics or not. We found this trend, and so just to show you real quick. But I agree with Andy. It's if you go by evidence-based, I don't think you can say that you have enough evidence for indomethacin. So that's something that I love to see a randomized trial on. Next,
one of my patients last week was given it by their local clinicians. I certainly wouldn't say it was wrong, and I certainly wouldn't discourage them to do that.
Okay.
But our current practice is not to at the moment.
Yeah, and I think that's what people want to know. What the experts do based on the best evidence. The next thing, I guess, as I'm moving through the cerclage, so now we're getting to the thick of it. Needle size and suture, and you showed a great variation. And I guess the summary seemed to be that the suture may not matter that much, you kind of say, and then the needle maybe should be as small as possible to go as high as possible. Any comments on those things? Suture first.
Well, to me, it just makes simple sense. When you've done enough of these and you've tried to, not go too deep and actually maneuver your needle as high as possible. If there is an agreement that higher is better, then it's much more difficult to get it high with a great big needle. And I think that's what we showed in this study quite clearly.
Clinicians have frequently commented to me, "Gosh, can't we have a smaller needle on the mersal intake?"
Yeah.
Interestingly, I've tried to contact the companies a number of times, and they don't seem to be interested in doing it. And maybe we'll push again because we have some evidence here that suture the needle size actually changes practice, and we're going to evaluate that further. Your question was, what about the type of material? Well, in the C-Stitch trial, there were over a couple of thousand people randomized to braided versus monofilament. Absolutely no difference. I think 8% in each arm of preterm delivery. There were various signals of things that might be slightly different, but didn't translate into anything that's clinically important from the baby or mother's perspective. You know, the monofilament was slightly harder to get out. There may have been slightly less infection with the monofilament in a sort of not very categorized way. So the jury is out. You know, you can't say that this big science that suggested the microbiome was radically better with the monofilament has translated into anything clinically important. And I think people should use what they want to use. My own preferences, I prefer tape. I was surprised in this study that you couldn't get more tension with the tape, because I think it's easier to tie. I use both, and if one of my patients requests one, I'm very happy to do it. If I have a blank sheet, I tend to pick tape, particularly for the physical exam indicated ones where I think the cervix can be a bit friable and the monofilament might pull through. So again, this is personal preference, and hard to have strong evidence one way or the other, is my view.
You know, interesting enough, I also use Merceline tape. Not all my colleagues do, the majority, since I train most of them. But I think I agree with you, the jury's still out. And I want to put a pat in the back again. The C-Stitch trial, such a huge trial, so important. You know, these trials can be done, and 2,000 patients randomized. You know, we need trials like this. I guess one thing that surprised me when Graham presented his slides is that some people use a cutting needle. I use a round as well. Any comments on that? I think cutting obviously will bleed more.
I was fascinated by that. I think there are people like I personally would use monofilament now, because I got so fed up with the big needle of tape. So when I started randomizing women into the C-Stitch study and it said you could use monofilament, oh, great. So I went to our theatre stock room, looked amongst all the monofilaments, found the best one for me, found one with a small needle, and then started using that. And I think some people will be in theatre and they'll say, to the scrub nurse, give me a monofilament. And then they'll just take what they're given, and there may be an element that people are just quite happy to use what they're given rather than necessarily actually thinking it through and thinking implications. But if the people using the cutting needle actually deliberately chose to, it would be very interesting to know why.
The next big thing I want to talk about, really, so you now decided the suture, and then the needle size and round, whatever. Then you need to start the cerclage, and how high do you go? And that may be actually, to me, the most evidence-based thing that we have. You showed some data, Andy, at the beginning in your slides from UK data. We've looked at this. Others have looked at this. Byzantine is one of our papers. Rust, we collaborated with them, and there's no question that the higher you place it, the more. One of the studies we found 18 millimeters. We currently teach try to go 2 centimeters or more in any cerclage, history, ultrasound, or physical exam indicated. I know it's obviously harder with an open or short cervix, but I think that's the most evidence-based thing that cerclage technique can offer now. Any comments?
The general principle, I think, is get the suture high. It's interesting because we never see our colleagues operate, but our juniors see our colleagues operate. And when my juniors do it with their colleagues, with my colleagues supervising, and they go, "Why are you going so high?" And I said, "Well, Andy goes high. That's what he does, And they're all frightened. They're all frightened to go high. So I think there's a matter of experience. I do what I do, and I know where it is on scan. And I think my colleagues are worried about the bladder. Yeah, I've never knowingly gone into a bladder, even though I seem to do much higher than they do, just with the confidence of what I do. and obviously we can mobilize the bladder if there's concern about it, etc., etc. So I think you have to individualize it to the different patients. I don't think routine mobilization has a whole lot of evidence, but I do think there are individual cases, particularly after cervical surgery, where you clearly can get the stitch a lot higher if you mobilize the bladder for safety reasons.
Yeah, and just on that, we're acknowledging again Andy's point that we all think the way we do it is best. Back to your point about the retractor, I make sure that the retractor slides down presses hard onto the cervix and pushes the bladder back. And then I really go as high as I possibly can. And then I go a bit higher still. And simple stuff. I make sure the woman went to the bathroom just before she entered theatre, and then I just do an in and out catheter at the end. And I've never had one with blood in it, you know. So you kind of hope and assume that you haven't. And like Andy, well, I've scanned them afterwards. But I have a couple of the cervixes from the trial here just in front of me. You know, these just randomly picked out. This is one, you know, it is so interesting that despite having the opportunity of a 50 millimeter cervix, some people, this one, clearly that person didn't sort of really think that was important, or did they think they'd got it as high as they could? I simply don't know at the moment.
Yeah. No, I think it's so important, and you know, I do the same. You know, there's so many steps again. You know, every time I talk about this. So we also empty the bladder. I actually put, since I usually don't place a cerclage besides a trainee, but I teach them before and after, and I actually use a marking pen and put 4 dots as we go one by one as we go around the cervix to tell them where they go. To me, the bladder refraction, a lot of people say, bladder refraction, you can't go above that. I, like you, Andy, I don't think I've ever knowingly been in the bladder, doing a cerclage, and I think I've been very close because I do ultrasounds before and after. But in my experience, maybe I get to 1, 2, 3 millimeters from the bladder, but I'm 2-3 centimeters from the external walls, and those are the ones, at least from our data and your data, that seems to do the best. So I'm glad that we agree, and I think the data from many different studies agree on that. And that's why I think another message we can send, people ask us all the time, McDonough, Shirokar, what technique to use. It really doesn't matter. I think I place a McDonough as long as I can go high. And like you said, Andy, rarely you can dissect the bladder if you think you don't have enough, but usually 99% of the time you can just...
In one of our trials, we routinely randomized, when we're comparing abdominal to vaginal, into mobilizing the bladder and not mobilizing the bladder, and there was identical outcomes when it was routinely mobilized compared to just put in. And there's quite a lot of trials showing there's no real advantage in routine mobilization of the bladder. Yeah. I think it has to be individualized to surgical need, I think.
Another thing that you were showing, now, we are going high. The next thing is how you place those bites. And again, this is a picture from a while ago, just to guide our thinking. It probably actually doesn't really reflect what we do that much, but we place kind of four things, and I always teach that actually this actually a good picture for that the posterior bite, in our experience in our studies, is the one that comes off the most. Seems like it's more friable, thinner posteriorly, or you just don't go as high and as deep. You tend to place shallower bites. Any comments on where to place the bites?
Yeah, I've not seen any evidence for that, but I found it anecdotally exactly the same. When it does come undone, the posterior one comes out first.
Yeah,
my experience, and I think I always encourage the juniors to take a big bite and not worry, because there's nothing there to damage. The pouch obviously can have bowel in it, but in practice, it's never an issue.
It's a picture of one that many years ago kind of came off, and it's only anteriorly, not the cervix is opening, but you're not around the cervix at all, which was very sad to see. Any comments again on the bites? I guess related to that now, it's also the tension. I must admit, I've been doing this for a long time, and I never thought too much about studying the tension, and it's so interesting, how much people kind of kill it.
So I think they're related, because if you have very deep bites, you have very little stroma inside the suture. If you also pull tight, the risk is the whole thing's just going to pull out. And equally, if you have very shallow bites and you don't pull tight, you have huge potential for things to prolapse and the stitch to be dysfunctional. So they aren't unrelated, and we just have the evidence about how they interact. And what you need is enough tissue inside. I tend to leave a lot of tissue inside and pull tight, and that way it doesn't pull out and it doesn't prolapse. That to me seems the most logical thing to do.
Yeah.
Yeah, and just to add to that, it always made sense to me, like the original McDonald description, that if actually the idea of it is to circumferentially squeeze a cylinder, the deeper you are, the more tissue there is outside your cervix that's just quite happy on its own and not being squeezed by that purse string, if you like. So I see the bites as a kind of transfixion to enable the suture material to actually squeeze it. But I often wonder whether I pull too tight. Like I said in that video clip, I tie it's a sailing knot, it's a slip knot. So even with monofilament, I can make it really, really tight. And am I going too tight? What is too tight? I just don't know. But the one thing I'm sure of is not tying the knot at all is a waste of time. But where on the scale should we be?
Yeah. And I again, it's only opinion here. I probably used to kill it, so to speak, make it really tight. I probably don't make it as tight, thinking that you want to maintain some of the cervix, but I certainly make sure that it's indented, all around, that I'm all around, after I place it, before I tie the knot, put a finger in the cervical canal, and I make sure that I feel the knot, that it's tight, and I cannot go above. And with Merceline, I think there's no good data. You place a surgeon's knot or a regular knot. The first knot you throw down, but I make sure that the resident, everybody else, feels that the cerclage is high, and it's nice and keeping that cervix tight. And then I guess 80% in your study did anterior.
Just about to that point. Of course, in the study, as I mentioned, people are able to get them tight with monofilament, and they're able to tie them loose with Merceline. I was quite surprised by that. Mm-hmm. Yeah, 80% anterior and 20% posterior. And people have got strong and opposite views. The people who tie it anteriorly seem to think that it's easier to find and easier to remove. The people who tie it posteriorly say that the knot is going to inflame the bladder and cause all sorts of trouble through the pregnancy. I don't know. I leave mine anteriorly. I think I worry about the woman and the resident having to remove them at 4 a.m.
Andy?
Yeah, I don't know. The jury's out. So we don't know. I like to tie anterior.
Okay, and we place 4, 5, 6 knots on the Merceline. I don't think it makes any difference. I don't know how many you place.
7.
7. There you go. Okay. 7. Your data versus ours.
Yeah.
Okay.
Yeah.
And one of the last thing, we're almost at the top of the hour. We'll conclude soon. This has been an amazing conversation. It's do you ever place a second on the same cerclage session in the OR? Do you place a second stitch? I can tell you, we probably less than 1%. But I guess go ahead.
I've never put a second stitch in at the same time.
Okay.
I have put a second stitch in later and left one just because it's not looking tricky to remove. I do put 2 stitches in my abdominal cerclage to get a cylinder of support, but not vaginal.
Graham?
Yeah, no, never have. I've heard fairly convincing arguments. you put one in to actually kind of pinch the cervix shut, and the other one closes the external canal. Yeah, I think we're sort of traumatizing the cervix enough without having to put 2 sets in as a planned thing. But I know, again, people will swear by it, and we don't have the evidence.
Yeah, and I think that one of the concluding remark here is that the more you know, the more you don't know. That's what I teach people all the time. The more you look at the data, the more you find that it's very limited, and there's a lot more to study. We could talk about this for a long time, but I think we're at the top of the hour. I may actually ask you two guys to come back again to discuss other issues, but we did go from the beginning to the end of the Cerclage technique. I don't know, Graham, if you have any final thoughts or final messages you want to share.
No, just great thanks for giving us this opportunity. It's been really fascinating for me. Thank you.
Yeah, I'm really delighted that we have so many common conclusions given our independence. And this is like a start of a journey. As we've shown, that the variation here is staggering, and I think we can do better, and we need to work out the best thing to do. And thanks for the opportunity to share these thoughts.
Yeah. Same here. An hour ago, I had never seen a thread. You showed the loop on top that people. Yeah. I never heard or seen that anywhere in the U.S. So I think we're on the same page on many things, and there's still some lots of variation. So looking forward to more studies from your groups, and from everybody who's been listening. Again, thanks for being on with AJOG MFM, the Pink Journal. Thanks for publishing great research, all of you listening, and Andy and Graham here. Thanks to the young investigators helping us out, and have a great rest of the day. Good afternoon.
And thanks to Laura for doing all the work.
Yeah. Thanks to
the whole team. Yes, thanks to the whole team.
Yeah, of course. Yeah, sure. Thank you.